One, please start, sir. We are live.
Okay, so good day, ladies and gentlemen, and welcome to another series of the Global STAR webinars. The STAR webinars were initiated with the intent of sharing best practices in the field of epilepsy in the year 2023. So after a very successful first series, we have now initiated the second series this year in 2024 with the theme of epilepsy and its comorbidities. The first webinar in the series, which was conducted in the month of April, talked about comorbid stroke in patients with epilepsy. For this webinar, we have a very interesting topic, temporal lobe epilepsies with psychiatric comorbidities. And let me introduce our speaker for today to all of you, Dr. Alison Richardson, who is a consultant neurologist at Christian Barnard Memorial Hospital, South Africa. Dr. Richardson is a member of the Health Professions Council of South Africa and ex-committee member of the Neurological Association of South Africa, NASA. She's a member of the Movement Disorder Interest Group in South Africa and has received international training on deep brain stimulation and Botox techniques. She's had several publications in medical journals and books, including the MIMS and GP handbooks, and she has been a KOL speaker at various national and international congresses. Dr. Richardson, it's a pleasure and honor to have you here for this second STAR webinar of 2024. Welcome.
Thank you so much.
Joining us as a panelist today, we also have Dr. Grace Mokome. She's a general neurologist at Louis Pasteur Private Hospital and Medclinic Forum Hospital in South Africa. Dr. Grace is a highly skilled and motivated and responsible neurologist. She has special interest in epilepsy, strokes, movement disorders, and neuro-ophthalmological disorders. She's currently based in private practice with previous state experience. Dr. Grace, welcome to this webinar. And with this, I would like to hand over to Dr. Richardson for her presentation.
Thank you. Just checking everyone can see this.
Yes, we can.
Okay. Good afternoon, everybody. I'd like to thank Zydus for the opportunity to give this presentation. I'm hoping that we all take something home from it, and I've tried to keep it as interesting as possible, a lot less sort of charts and tables and a lot more hands-on or clinical discussions. We're going to be talking about temporal lobe epilepsies, and in particular where there's a lot of psychiatric overlap, or what the association is between the temporal lobe epilepsies and psychiatry. And the psychiatrists and the neurologists know that there's always a huge amount of overlap between the patients that we share. So, as Hardik said, I'm Dr. Richardson Alison. I'm the consultant neurologist at Christian Barnard Hospital. Sorry, I've skipped a slide there. No. Christian Barnard Hospital is based in Cape Town. In case you didn't know, it was the place of the very first successful heart transplant in South Africa, well, in the world, actually. So it is quite an honor to be there. So for today, we're going to talk about a couple of things, just a general outline. So what is temporal lobe epilepsy? What are the subtypes? Lots of memes for your entertainment. The psychiatric comorbidities and TLE, your drugs, so the psychiatry drugs versus my drugs, the neurology drugs. A little bit of the psychiatric manifestations and TLE, what our management options are, and then we'll end off with any questions, complaints, or compliments. I will start with just a little bit of background knowledge. The temporal lobe, we have one on either side, obviously, and it's largely responsible for memory, processing sound and vision. and quite important for recognizing objects and language. If we look at temporal lobe epilepsies in isolation, it's the most common focal epilepsy in adults, so it represents as many as 25%. It causes 60% of our pharmacoresistant seizures, with pharmacoresistant being defined as a failed trial of more than 3 drugs over an adequate amount of duration that they've been taking it, which generally we take at about 6 months. So if they failed 3 different drugs over 6 months, we start to get a little bit concerned. And that's why it's the most commonly referred for epilepsy surgery. As high as 70%, because very often we don't win with medication. If we look at the classification of TLE, we've got the mesial temporal lobe epilepsies and our lateral temporal lobe epilepsies. And the more important one that we're going to focus more on in terms of temporal lobe seizure etiology is the mesial temporal lobe, or MTLE. This involves the innermost structure of the temporal lobe and includes the hippocampus, the parahippocampal gyrus, and the amygdala, which are all related to emotions and memory. It's the commonest form of TLE, and it's generally secondary to something called hippocampal sclerosis, which we'll touch on briefly in a little bit. If we look at our lateral temporal lobe epilepsies, these are otherwise known as our neocortical seizures. They're pretty rare, and they generally relate to genetic or acquired anatomical lesions, so tumors, arteriovenous malformations, neuronal migration disorders. Okay, so no epilepsy talk would be complete without throwing in the International League of Epilepsies classification. I'm not going to go through it in great detail. Just to say that, again, it falls under our focal epilepsy syndromes, and a very brief comment on the FMTLE. Those are generally associated with focal aware seizures. So a lot of patients, 70% in fact, have deja vu. If we do the EEG, there's a bit of temporal slowing, so not very exciting. And then often we don't see an MRI abnormality, but we get very excited if we do see a hippocampal atrophy or hippocampal sclerosis, because that is a marker for the potential responsiveness or non-responsiveness to medication. Again, just a brief note, the seizures are generally focal and cognitive. They do not present with generalized tonic-clonic seizures. Our EEG can be generalized abnormal, often associated with intellectual disability. We may find some focal abnormalities on neurological exam. As I said, the hippocampus can be normal or it could be sclerosed. And then we've got our genetics, which may give you a family history, or if you get a family history, rather, of focal seizures that have potentially arisen from the temporal lobe. So very important, we need an MRI, just like all neurologists need an MRI, because we want to make sure that nothing else is causing the problem. I know that that's not always possible in resource-constrained countries, but at the very least, a CT scan can be performed. We don't technically need an abnormal EEG, mostly because, you know, your pickup of an EEG is not necessarily guaranteed. So I'm sure we all end off our EEG reports with a normal EEG does not exclude epilepsy. So, you know, at the very least, a CT scan or an MRI, and then a normal or an abnormal EEG. Okay. To talk about what hippocampal sclerosis or Amon's horn sclerosis actually is. So it's a neurodegenerative process that is considered the major cause of temporal lobe epilepsy, and it's associated with a decreased hippocampal volume and an increased signal intensity. So if you look at the picture on your left, or my left, you'll see the yellow arrow pointing to the hippocampus, and you can see if you compare it to the other side that there is a little bit of atrophy, there is signal intensity. And then if we go on a microscopic level, we're talking about neuronal loss in the CA1, 3, 4 and dentate gyrus with sparing of C2, but obviously that's not something we can make clinically. And then we've all heard the saying, which is not set in stone, but in patients who've had a history of febrile seizures in childhood, and in particular prolonged febrile seizures, are much more at risk with causing this hippocampal sclerosis to occur. If we cast our minds back, and I'm not going to spend long on this slide, we look at embryology, and we can see that your normal hippocampus is structured in picture 1, and then your types of international league severity of it is as you move along the pictures, and you can see that the amount of damage or neuronal gliosis leads to a more significant impact clinically. So to summarize briefly, the hippocampal sclerosis in mesial temporal lobe epilepsy is now associated with psychiatric symptoms in up to 70% of our drug-resistant epilepsies. So lovely if we see it, lovely for us to make calls or to postulate what could potentially happen. We're not always that lucky, and that's why we're going to go into a little bit more detail further on in this talk about what we would look for clinically as opposed to structurally. So what us neurologists like to hear from patients are typical seizure patterns. We ask about affective experiences. Often we hear that the patients have anxiety, but it is not an anxiety per se, you know, that you've overspent on your credit card anxiety. It's an intense ictal fear, sorry, and occurs suddenly. So it's not generally provoked by something. They can be intense, and often my patients say to me, I can't describe it, which is sometimes quite a telling symptom to hear, because patients find it difficult to put into words how they experience it. You know, patients can say, I'm anxious, or I get the butterflies in my stomach, or I feel a bit nauseous. But a lot of patients who say to you, I don't know how to tell you how I'm feeling, is something to listen out for when you're considering a diagnosis of something like this. We often see cognitive abnormalities in TLE, and these include disturbances of speech, memory, and thought. 50% of temporal lobe seizures are associated with vocalization. So patients don't generally talk, they don't exhibit words, which is sometimes the difference between your frontal lobes and your temporal lobe epilepsies, because the frontal lobe epilepsies verbalize. So your non-verbal vocalization doesn't really help you localize in terms of whether it's left or right side of the brain. It's just an association. What we often see, which is lovely, is patients who give automatisms. So this is thought to be preserved speech during the seizure discharge. Patients will smack their tongues, they'll go it's often irrelevant. And if, for what it's worth, if we do get this, it's a non-dominant temporal lobe focus. Our disturbances of memory is often how we end up seeing patients. So you'll get a patient referred from a GP who says that Mr. So-and-so has a 3-month history of gaps in his memory. He's youngish, healthy-ish. He's talking to his friends or family, and they'll say that he kind of switches off for a minute and then he comes back. So these range from sudden difficulty to recall, or they can compulsively reminisce on topics, scenes, or events from the past. The essential quality of recognition can change with feelings of familiarity or unfamiliarity, which leads us obviously to our classic textbook diagnosis, symptoms of déjà vu and jamais vu. So the feeling of being somewhere before or not being somewhere before that you had been. If we get disorders of thought blocking, forced thinking, incoherent talk, these are rare and less specific for TLE and should probably point the attending specialist to consider a psychiatric or an overtly psychiatric etiology. Again, I love to hear this from patients, our hallucinations and auras, our hallucinations of taste and smell. These come from the medial temporal lobe, and in particular our amygdala. As I said, considerable significance. Patients very seldom say that the smells and tastes are pleasant. I've had variations from blood, metal, pesticide, or what I guess people would imagine pesticide tastes like, because I'm hoping nobody's actually tasting pesticide. And you can see these particular features in frontal lobe features, but they're much less common. And the reason for that is just because of the spread of the ictal focus from the temporal lobe to the frontal lobe, which is why you would be more likely to see it in a temporal lobe epilepsy. Then we have our visual illusions, our objects appearing larger, macropsia, or smaller, micropsia. I didn't know this, but inclined at an angle, which is plagiopsia, elongated or flattened. Your achromatopsias, or infused with a specific color. Patients can describe complex visual hallucinations of scenes or faces or visions of past experiences. Doesn't help in terms of lateralizing it to medial or temporal lobe. And auditory hallucinations often vary. They can be simple or complex. They can be ringing, buzzing. Some patients hear music, some patients hear voices. So you can see that a patient who presented to a psychiatrist or a patient who presented to a neurologist or something like this, your first thought would probably be that this is a psychiatric issue and not a neurological issue because of the variations in the presentations. So no patient is the same, as I'm sure you know, and everybody has a different experience. Generally, our seizures march. So this is where you would start to, again, take your diagnosis back to the neurological side. It would start with your epigastric, for example, sensation, move on to the smell. You could start with déjà vu, and then you could become, your ictal fear. And again, here's tying back to my comment earlier that patients just say they think they're going mad because they struggled, again, to describe what they are experiencing in words. Our ictal seminology in TLE, dystonic posturing, which is the hand or arm, we see in 70% of temporal lobe seizures, and is often indicates a contralateral focus, so right arm, left focus. Slow gradual recovery with post-ictal delirium over several minutes is characteristic, and headache is common. Coming back to our automatisms in TLE, we've said that these are repetitive, involuntary, purposeless movements that are inappropriate. Our most frequent ones are lip smacking, chewing and swallowing, or gestural, being fumbling, picking or rubbing. Again, not huge amounts of localizing value, but if the gestural automatisms are unilateral, then your focus is ipsilateral. I've also seen patients complain of ictal speech. They grimace. By wondering and searching, I mean that they'll put their hands out on a table, perhaps to look for their phone, but they can't actually see their phone because they're having a seizure. So their hands will wander around trying to feel the outline of the phone. Our prolonged nature of automatisms is also a feature of TLE, so it does last several seconds to minutes even. And then our lower limb automatisms, so pedaling or kicking, is rare in TLE and is much more commonly associated with frontal lobe seizures. So if we move on a little bit now to our prevalence of psychiatric comorbidities in TLE, we can see that patients who have the mesial temporal lobe epilepsy variant, 25% are mood disorders, there's anxiety disorders, and there's psychotic disorders. And obviously these are important because, you know, their seizure burden is increased. They're much more prone to have common seizures. We end up putting them on several anti-seizure medication types in attempts to get them under control before we consider the surgeries. As I said, the presence of hippocampal sclerosis, and then the huge disruption that just this type of seizure disorder has on families, and I'm sure it's similar in your countries, perhaps in South Africa as well, is if patients present like this, it is the culture of South Africans often to assume that patients are possessed or they need to see a witch doctor. And this kind of delays treatment a lot as well because of the lack of education. And then there's a big stigma attached, as we know, to the psychiatric comorbidities and TLE. So again, if we look at our TLE psychiatric symptoms and epilepsies occurring elsewhere, so extra TLE meaning outside of the brain, or outside of the temporal lobe rather, you can see that depression and anxiety are almost double as common in our temporal lobe versus our extratemporal lobe. So again, comparing our TLE and idiopathic generalized epilepsies, so our temporal lobe localized epilepsies versus our generalized epilepsies affecting the entire brain, we can see that the temporal lobe is hugely responsible for the psychopathological symptoms. We get our Axis 1 disorders, which we touched on, in the slide before. We get an association with obsessive compulsive disorder. We get an association with phobias. So it's not to say that your generalized epilepsies are not associated with psychiatric comorbidities, but you can see that it's obviously much more common by nature of the temporal lobe itself and everything that it controls. A little summary, you can see that our mood disorders 3 times more common in the general population compared to TLE. Anxiety disorders twice as common, psychotic disorders 3 times as common, substance abuse. Funny enough, the general population is more guilty of that. This is just to show you more for interest sake than anything else. If you're looking at whether your hippocampal sclerosis is on the right or if it's on the left or if it's bilateral, you can see mood disorders, anxiety disorders are much more common if the left mesial temporal lobe is affected. Our psychotic disorders much more in bilateral sclerosis. And then our right mesial temporal lobe, a little bit of mood, a little bit of anxiety, a little bit of psychosis. So the one take home, if we get it, that you can take home from today's talk is that the presence of psychiatric comorbidities as well is associated with a significantly poor quality of life. And that's why it's important to identify it and manage them accordingly. Interestingly, psychiatric disorders can follow the onset of epilepsy, so patients have a diagnosis of epilepsy already, or they can precede the very first seizure and actually serve as a risk factor for epilepsy, which we see in depression, suicidality, ADHD, and psychotic disorders. So important to note that patients can present initially with neurobehavioral disorders and not have had a seizure yet. Okay, so the 3 stages of an epileptic attack, which I have tried to break down as much as possible. We've discussed our pre-ictal phenomena earlier with the automatisms and the auras and hallucinations. Our interictal epileptic attacks are very, very exciting for the psychiatrists. And of course, our post-ictal patients are fun for everyone. If we look at our interictal psychosis with the overlap, we get a personality, or we can get personality disturbances in patients with epilepsy. These guys often present with excessive religiosity, which our psychiatrists will know increased participation in overtly religious activities. They become overtly concerned over moral and ethical issues, very preoccupied with what is right and wrong, suddenly interested in global and philosophical concerns, and may sometimes actually seem like the prodromal symptoms of schizophrenia. Another way that they can present is a viscosity of personality. So these are patients where, you chat to them, people that know you well chat to them or know them well, and it's picked up in the conversation. So they notice that someone who was okay before is now slow and serious and ponderous, and repletes us with completely non-essential details, and they're often circumstantial, which, if I'm honest, sounds like an average day of patients for myself. The listener can grow bored, but can't find a way to sort of exit the conversation. And interestingly, the speech tendencies are mirrored in the patient's writing. So they result in a symptom called hypergraphia, which is writing excessively as well, and which some clinicians can consider virtually pathognomonic if you pick it up for complex partial epilepsy. Some of our patients have changes in sexual behavior, so they can become hypersexual. They have deviations in sexual interest. I thought the transvestism was an interesting component. Hyposexuality, which can be a lack of interest in sexual matters or a decrease in sexual arousal. And then we move on to our post-ictal psychosis. So these are generally brief, self-limiting, end within, seconds to minutes to hours, hopefully. The problem comes in if the psychotic and affective features are occurring after the patient was, quite lucid after the seizure itself. So patient has a seizure, is completely fine for a period of time, and then becomes psychotic or depressed or anxious or agitated. And this is something to look out for. It's the most common form of psychosis in patients with epilepsy. And a small percentage of patients develop chronic ictal psychosis, which unfortunately is every time they have a seizure, they have a psychotic episode shortly afterwards. If we look at our axis 2 disorders in temporal lobe epilepsies, it's been a sort of common finding or a highly significant relationship between personality disorders and epileptic auras. Personality disorders. So I hope this makes sense, but no patient who did not experience an aura had a personality disorder. So if we say that again, no patient who did not experience an aura had a personality disorder. So patients don't have auras, unlikely to be associated with personality issues. There's no association with the epilepsy type or the laterality left and right. There's no relationship with age, duration, or seizure frequency. And then I'm sure our neurologists see it, but our patients become extremely anxious when they've been diagnosed or when they start to present with seizures or with these types of symptoms. They become afraid of going out. They become afraid of going out alone. And as a result, pathological avoidant or dependent traits may develop. I'll take you now to a case study because everybody loves a case study. And I'll give you the case of a gentleman that was seen at my hospital. He was a 62-year-old gentleman. He had a high 20-year history as given by himself of a medical history of hypertension. He was diabetic, he was hyperlipidemic, and he'd had a seizure prior. He was brought initially to the hospital because he was acting bizarre. The patient said that he'd had an episode of generalized tonic-clonic activity 5 days ago whilst walking outside, associated with a loss of consciousness of unknown duration. He denied that he'd hit his head at the time. He was taken to the emergency room, and as you can see, our full blood counts, our metabolic panel, liver functions, ECG, and CT were all unremarkable. And he was discharged the following day after being kept for 24 hours observation by the physicians. All of a sudden, he was brought back, with the family telling us that he'd become extremely active after this event and was found to be talking excessively at home, which was unusual for him. He said that he was having delusions of paranoia, that people were chasing him. He was seeing dead family members at home and was reported to be pacing up and down. His appetite was significantly impaired, and he refused to eat and sleep for at least the last 3 days. So this is now after he'd been discharged. He himself admitted to having a lot of energy by saying, "I want to record a video on the internet." I did try and find out what type of video in case it would be worth watching, but it was a no-go. At the time of his admission, so when he came back, he had a very elevated and expansive mood. He had rapid speech with flight of ideas, and he was extremely disorganized thought-wise with delusions of grandeur, as he told me that he owned the universe. We subsequently ordered an EEG, which showed a diffuse slowing of the background, but unfortunately no epileptic foci. He denied any fevers, chills, headache, weakness, numbness, tingling, neck pain, double vision, chest pain, shortness of breath, and palpitations. The only thing of significance was that his sister told us that he'd had an alcohol-induced seizure again 10 years ago, and then one prior episode of post-ictal mania associated with that lasted for a week. He didn't see anyone after that, it seems. I gather that he was non-compliant in terms of following up. There was some mention that the GP had started him on an anti-epileptic drug, but he sure didn't take it for long. When he came back, we initiated treatment with sodium valproate with a load, and then we gave him orally twice a day. We put him on olanzapine, folic acid, thiamine, and aspirin, and fortunately, he showed quite an improvement. So the big question is, if we look back on everything that we've talked about so far, who is the ER going to turf to? They're going to call the psychiatrists, or they're going to call the neurologists? It's an interesting question, and we'll answer it in the next slide, but just take a moment to consider what you would, where you would send this patient to. So in this case, we're actually dealing with complex partial seizures. And there's 4 characteristics that cause us, or should cause us, to be much more suspicious than usual as to why this is going to neurology rather than psychiatry. So this is the abrupt onset of a psychosis in a person who was previously regarded as psychologically healthy. He had that seizure 10 years ago, but it sounds like that was alcohol-induced. He presented with an abrupt onset of delirium with no recognized cause. Remember, we did the bloods, everything was fine. He has that history of a similar episode, which had an abrupt onset and recovered spontaneously. And sometimes these patients will say that they have had episodes of syncope or falling or fainting spells. So these are all characteristics that sort of point to, could this be more neurological than psychiatric? If we move on now to our, I don't have too many slides left. I don't know how much time I have. You know, I always joke with my patients and I say that God did not bless neurologists and psychiatrists with a great number of drugs. We were sort of right at the end of the line when he was handing them out. And there ends up being quite a lot of overlap between, you know, neurological drugs and psychiatric drugs. And unfortunately, the limited amount of drugs available to us means that there's a lot of side effects. So from a psychiatric aspect, a couple of our antidepressants are problematic. If you look at it, it's generally our TCAs. Our intermediate risks are our SN and SRIs. And then our safest drugs are our monoamine, I wouldn't say safest, maybe least risk are our monoamine oxidase inhibitors, which kind of takes out a lot of our options in terms of psychiatric antidepressant drugs. These are the psychiatric drugs, again, that lower our seizure threshold. So now we've got to look at our antipsychotics. So our clozapines, chlorpromazines, huge risk for lowering seizure threshold. Our intermediate drugs, and then our potentially safer drugs would probably be haloperidol and pimozide, which are available in South Africa. I included sort of drugs that we don't get in South Africa in case you guys get them in the country where you are from. So, moral of the story, in patients with temporal lobe epilepsy, or in fact patients that you're seeing for non-temporal lobe epilepsy that could actually be temporal lobe epilepsy, you've got to be quite careful about what you put them on. This is just for a brief mental health break. So when you have seizures, but seizures are caused by anxiety, but anxiety is a side effect of a seizure, so it's just an endless loop. I included this slide, again, just for entertainment's sake. Reflex epilepsies, so not of any relation to temporal lobe epilepsy per se, but apparently there's a thing called hot water epilepsy. So persons get seizures if they pour hot water on their head, and it's been reported from South India and from Bangalore in particular. I assume this relates to some kind of stimulation in the focus of the brain. What could be the worst type of epilepsy ever would be the eating epilepsy. So seizures are precipitated when a person starts eating food, and it's thought that it's the repetitive masticatory and mandibular movements that trigger it. We already know that watching TV can precipitate seizures in individuals, which is the sort of photic stimulation that we do in EEGs. And then our hyperventilation can precipitate seizures as well. And we do hyperventilation when we do EEGs in patients, in the hopes to provoke a seizure when we are performing an EEG, that is. So this is the fun thing about the brain. You know, we've been around, it's evolved over hundreds of thousands of years, but if you're epileptic and you put a flashing light in front of it, it shuts down and can cause a seizure. This is the EEG of a patient with hippocampal sclerosis, and in particular our complex partial seizure type of picture. If you look where the arrow is, what we like to see, what is virtually diagnostic of temporal lobe epilepsy, is a 3 Hertz spike and wave that manifests generally over our temporal and can sometimes extend to our frontal lobes as well. So before the arrow, you can see that there's normal brainwave activity, which is 9 to 13 Hertz, and then all of a sudden you've got an abrupt onset, which is localized in particular just to sort of, I haven't got a pointer, so that doesn't help, but you can see the abnormalities over F7, T3, T5. And then a little bit of it extending if you look at the top to F3 and C3. So this is essentially a left-sided seizure focus of the temporal lobe. And as you can see at the bottom, he's got left-sided hippocampal sclerosis. This is always fun. We try desperately to catch an abnormality on our EEGs, but most of the time we don't. So again, it ties back to being a clinical focus, and we always joke that the patient will have a seizure or a temporal lobe seizure, 5 minutes after we've taken 300 electrodes off their heads. So almost done in terms of continuing. If we look at diagnosis and management, so everything that we've discussed, there has to be a way to at least improve quality of life. And it comes down to recognizing that psychiatric features are an issue. We need to make sure that the symptoms are not related to seizures, and they're not related to a side effect of one of the anti-seizure medications. So, it's obviously important to control your seizures because you're not going to improve the psychiatric symptoms without improving your seizures. And then our comorbidity psychiatric disorders, the earlier the better in terms of treatment. Our treatment options, we've got cognitive behavioral therapy. It obviously doesn't affect the seizure outcomes unless we're dealing with a psychogenic non-epileptiform seizure disorder, which is an entire talk just by itself. But the aim behind cognitive behavioral therapy is just to improve the patient's quality of life. We look at our drug therapy. We are looking at our SSRIs, and I know that was sort of medium risk, but sometimes that's all that we have available. Our TCAs are not as effective, and then our, as we've said earlier, things like bupropion and clomipramine can increase your risk. So funny enough, patients that have treatment with an SSRI have seizure reduction as well, and I think this is largely because the anxiety that is associated with having a seizure is improved. So it's sort of a corollary theory. So again, we've improved the seizures and we've improved the anxiety. I think our last couple of slides are just the surgical management of mesial temporal sclerosis and intractable seizures. Okay, no, hang on, not done yet. This slide is just looking at the management of TLE itself. So we're not looking at the psychiatric management. About 60% of them will respond to your anti-epileptic drugs. 40% are drug resistant. You usually try and start patients on carbamazepine or oxcarbazine. There are better drugs out there, in my opinion, that aren't so carbamazepine-based. Levetiracetam, lacosamide, valproate, lamotrigine, and topiramate are all used. And often it doesn't end up being first line. It ends up being 3 or 4 of those drugs before the medical aid says, okay, the patient is treatment resistant. But these are all kind of worth a shot. If we look at our psychiatric comorbidities and surgical management, so it's kind of to point out that although we are treating patients, we're treating the hippocampal sclerosis aspect and we're sort of treating the seizure disorder, very often we don't win from a psychiatric disorder and vice versa. So if the psychiatric disorder is there, you're less likely to have a better surgical outcome. So this is just because it's an independent association between the preoperative anxiety and personality disorder and then the presence of neurological symptoms after surgery. So it's a really tight overlap between neurology and psychiatry, as you can see. This is a quick slide just to say that the cognitive behavioral therapy versus SSRIs, they both can improve depression, but the SSRIs, as we said, are much better in terms of anxiety. And again, both are going to improve quality of life. So now it's push comes to shove. What are we going to do? We've done 3 or 4, 5 multi-drug attempts. We've got 3 drugs prescribed. Patients still not responding. We've excluded our psychogenic non-epileptiform seizure disorders. And now we're really going to look at what else we can do. So I know I said initially that some patients don't necessarily improve after the surgery, but those are generally your personality disorders. A lot of your anxiety and depression improves after the lobectomy. This is for 2 reasons. One, because you are removing a part of the brain that triggers anxiety, and 2, the fact that you're removing the seizure focus or potentially removing it lowers the patient's anxiety. So unfortunately, if patients don't do well when it comes to doing the temporal lobe lobectomies, you end up obviously with much more depression. So looking at our medical therapy versus surgery, just at anxiety and depression, I mean, I could go through every single psychiatric comorbidity and compare it to surgery and medical therapy, but that's another hour talk. So you can see that, there's a lot of improvement in anxiety with surgical treatment being less than medical treatment. And if you look at the bottom, it just says depression but not anxieties are reduced by anti-epileptic intervention. So that comes down to the surgery improving the seizure outcomes. So to summarize, temporal lobe epilepsy represents a large proportion of epilepsies. We've got a big presence of mood, anxiety, and psychosis amongst patients with epilepsy. Our limbic structures we talked about, so it makes it quite complex because it's not just one tiny bit of the temporal lobe. The early recognition and early removal of any potential anti-seizure medications can better manage your psychiatric symptoms. Anxiety responds to medical therapy, while depression responds better to surgery, and CBT improves quality of life. So there's a little summary slide of all the pictures that I just showed you earlier in case you switched off. All right, this is our final slide. Hopefully our heads now look like this, and we've all taken something home. And our last slide. Thank you so much for this opportunity, Zydus. I hope everybody enjoyed the talk. I'll hand over back to Hardik.
We certainly did, Dr. Richardson. I think it was very, very interesting to see the clinical perspectives on the variations in the presentations you talked about, especially the case, which was just mimicking schizophrenia. I mean, it was really hard for anybody in the ER to find out if this would ever be a form of epilepsy, but really very interesting stuff here. And I think a lot of clinical insights, more than what we see published or reported anywhere. So thank you for sharing your experiences and insights about these different cases. Let me now, you're welcome. Let me now invite Dr. Grace. Dr. Grace, if you can come in. We would like to hear from you, your perspectives and experiences, particularly with the kind of presentations you have and also the management protocols or strategies that you use for such patients. Dr. Grace?
Grace? She's still here. I see she hasn't got her speaker or her video on.
Grace, can I request you to please switch on your audio and video? I believe she may have some problems. Meanwhile, Dr. Richardson, if you don't mind, can we take a couple of questions from the audience?
I was going to suggest that, yeah.
Yeah. So while we wait for Dr. Grace, Dr. Richardson, we've had over 150 doctors attending this across different parts of Africa and Asia. And Dr. Grace is here. And
She's back.
hi, Dr. Grace.
Yes. Apologies for that. Dr. Richardson, thank you for your beautiful and concise presentation, and also thank you to Zydus for this opportunity. So my experience has been the patients that I have seen, they usually come from psychiatrists, most of them, because initially patients present with psychosis and they present with features that are more as compared to what ER doctors find. They are more psychiatry than neurology. So a neurologist will say, I have a patient who has hallucinations, and these are not typical to what we would refer to psychosis as of schizophrenia. Can you please come and help and see how we can manage this patient? So I would see the patient, assess them, and we do MRIs, and the MRIs will have typical features of mesial temporal lobe sclerosis in the form of atrophy and high signals in the medial temporal lobes. And the EEGs will have some features of epileptiform discharges. And then you would put the patient on treatment for temporal lobe epilepsy. But the issue and the biggest problem that we have, or I have in my practice, is that you have cultural issues that come into play. And like Dr. Richardson has said, if you have a patient who says to you, I see people talking to me, and these are people who are my ancestors, they're talking to me. For us as African Blacks, spiritually, we think you need to go through traditional rituals first and then you'll be okay. So those are the challenges that I have, that patients will say to me, no, this is not epilepsy. This is something that has to do with ancestors. I need to do some certain rituals and then I'll come back to you if I don't get what I thought could be the possible problem. And you find challenges that patients will not be eager at first to be on medication. And that will be based on cultural and also on stigma, that I'm young and here am I'm supposed to be this example to my community, to my family. Now I'm running around talking to myself. Now I have to be on medication and people are labeling me as a person who has a certain type of condition. So in terms of other comorbidities, psychiatric comorbidities, most of the patients who will have the diagnosis of temporal lobe epilepsy, they do have depression. And the depression, from my perspective, it comes from the issue of I have this condition related to the stigma as well. And this is something that I cannot deal with, I cannot handle. So it becomes an issue that, you know what, this is too much for me. And they become depressed in that sense. And just this morning, I had a patient who has temporal lobe epilepsy and who's suffering from general anxiety. And I had referred him to see a psychiatrist to be managed for that. And I asked him, how is it going? And he's like, you know, I'm on medication, but I haven't assessed the anxiety because what I'm doing now is avoidance behavior. So I have decided that I'm not going to expose myself to people. I'm going to keep to myself. I'm going to focus on my family, and I'm also going to focus on my schooling. And this is a young man of the age of about 23 years of age. So now the important thing for me when I'm managing this patient is to look at them holistically and to consider the spiritual aspect as well, and to also involve the psychiatrist. So what to get to a good point in managing these patients, I usually call a family meeting. And because sometimes when you have a young person who's telling you, I'm having these things, and the elders are saying I need to go to a spiritual ceremony, we need to speak to the family and say, we understand you have a spiritual aspect to the whole thing, but just be mindful that your child have this type of epilepsy and they need medication, so that they understand that even though they need to do certain things, but the epilepsy is still there and the patient still needs to be on medication. But I must say, in terms of presentation, sometimes it's a bit of a challenge for our ER or the first point of call, the GPs, to say, where does this patient fall to? Where should the patient first consult to? And that is the challenges that we have. Thank you.
Thank you, Dr. Grace. I think you've raised some pertinent points, and which are also, raised by our very inquisitive audience today. The first point is when do you decide to order an MRI for such a patient? I mean, what triggers ordering an MRI or a CT scan for these patients? I mean, the question is for both of you, and you can share your experience with this regard.
I'll take it to start. Theoretically, and as I said in my talk, every patient should have some kind of imaging. It doesn't necessarily have to be an MRI because, as I said, resources are often constrained. But you need to make sure that there's nothing potentially either reversible or irreversible. What if a tumor is sitting there? What if the patient's had a stroke? What if it's an APM? So in all of my patients, in fact, and I only deal with adults over the age of 18, anybody with new onset seizures or with symptoms suggestive of seizures will get some kind of neuroimaging. Grace, I don't know if you have anything to add.
Yeah, that is also how I manage my patients. All of them will get some form of imaging. And most of them, fortunately, from my side, I've been able to get MRIs for them as opposed to CT.
Right.
Thank
I'll
you.
give you an example. I had a, oh, sorry, Grace.
No, you can go ahead.
Please go ahead.
I just wanted to give you an example. I had a young girl who was pregnant, which was referred to me from the obstetrician, with what sounded like absolutely classic absence seizures. She had absences, she had the word finding, you name it. She could have written the textbook on absence seizures. And I was quite hesitant to image her because obviously she was pregnant. And I thought, I can't not image this patient. She had no focal neurology. She had nothing on fundoscopy. Long story short, big fat tumor sitting in the temporal lobe. It was quite a difficult case because obviously we were struggling to control her seizures, and that's a whole story by itself. But subsequently, the bulk of the tumor has been removed. But that's just to show that this is a young lady, classic presentation. You wouldn't think twice about not doing an MRI or an CT in general, but this highlights the significance of doing an MRI or CT brain.
Yeah, very pertinent point, especially because, from some of the countries where the audience is participating from today, imaging is not a common practice, neither for patients with epilepsy nor for patients with psychiatric presentations. So, particularly if you look at the case that you presented, the overt psychotic features of that patient, what can you really tell the audience that what should you really look for, and where would imaging come in at that step? Which step would imaging really, help them?
Grace?
With the patient that Alison presented, initially, like if you don't have that neurological mindset or view of things, it would be difficult to say this is a neurological or a psychiatric patient. So I'm giving an example based on somebody who's just a GP. So looking at how he presented, you would think this is classical psychosis and it needs a psychiatrist. So now, but one thing that Alison highlighted is the acuteness of what had happened to the patient, and the patient the family having said that this patient was psychologically okay before this happened. So that should point to maybe we need to get a neurologist involved here to assess whether this is not temporal lobe epilepsies, or better yet, just get the both disciplines to see the patient, and from each perspective to see if is this a psychiatrist or a neurological point. But based on what she said, from my experience, I would have thought, let me look for a temporal lobe epilepsy or complex partial epilepsy.
Okay. I'm drawing one more point from what you said, Dr. Grace, earlier is you refer your patients to a psychiatrist. And do you often see that psychiatrists put these patients on, let's say, an antidepressant or something, and then, the data Dr. Allison showed that some of these medications could trigger epilepsy in that patients. So what is your experience like when you have a patient refer to a psychiatrist, put them on let's say an antidepressant, and then comes back to you with increased seizure frequency? How can you deal with that situation?
So with me, patients who are referred from a psychiatrist, usually they would come with some form of a psychiatric diagnosis. Let's say it's major depression, and they're saying we're picking up things like the patient is having seizures and they're uncontrolled. So I would speak to the psychiatrist and tell them, okay, this is the situation. We're having uncontrolled epilepsy, and this is how I want to manage the patient in terms of the seizures. Let's say I'm giving the patient valproate, and then you are in agreement with that because it will also help with the mood in terms of the psychiatry. So this is how we are going to manage, because I know their doses are not the same as the neurological doses for the control of seizures. So if I'm giving the patient higher doses of valproate, just know that I'm targeting the seizures to control them, but also the depression will also, the mood will also be covered for, and hoping that with that kind of management, we are targeting both, and then the patient will do well on that treatment, on that drug. And also emphasizing that though we are giving this medication that we're giving, please continue with your psychotherapy and the behavioral and whatever that you need to give from your side, so that the medication that we give can help and work for the patient. Thank you.
I think just to sort of touch on the question, if you really or you struggle to get an imaging, what you could potentially do is either your psychiatrist sees the patient or the neurologist sees the patient. You would manage for what you think it is. So you start the patient on your anti-anxiety medication, the patient on the anti-epileptic medication, but you aren't winning in terms of control. So it's not a hard and fast rule that, patient didn't respond to Epilim, but the levels are therapeutic, for example. You've added another drug 6 months down the line, patient is still symptomatic from a psychiatric component or from a neurological component. In those cases, I would really be pushed to do an MRI or a CT brain if I'd waited before.
Yeah. I'll take just one more follow-up question to that comment, Dr. Richardson, in the interest of time. With these patients, what is the extent of functional impairment you see, especially, like the patient Dr. Grace mentioned, the 23-year-old person, obviously displaying avoidance behaviors, is going to miss college or work. So in your experience, what is the extent of functional impairment that you see?
Sure. It depends obviously on the extent of the patient's symptoms. And the extent of how we manage it. Obviously, the anxious patient is more difficult to treat because they've already got the generalized anxiety. They become afraid of driving. They become afraid of picking up their children. They become afraid of going to school or university or work because of the stigma that's attached. So I don't think that there's a single patient with epilepsy on earth who doesn't have some kind of functional impairment or quality of life impairment. It just depends on the extent of the presenting symptoms. And everybody always asks me, can I drink on medication? So I suppose if you look at quality of life being the occasional alcoholic beverage, that's okay too.
Yeah.
Just to add on that, what I have seen with most of the patients is that now with the COVID situation that has happened and the working from home issue that was started, now what they're doing is that they feel that, with this epilepsy that we have and the anxiety and the depression that we have as comorbidities, can I as a neurologist motivate for them to work at home, so that at least they are able to perform that duty at home? And that is what I've seen with most of my patients who are epileptic, that rather than pushing me to go face the world out there or be anxious about driving or be anxious about being seen in public and having all sorts of seizure manifestation in public, rather write a motivation for me to work at home. And that, for me, if it's something that really helps the patient, it's something that I motivate for, and it will depend on the employer or the company to say, yes, we approve this or we don't approve this. But that is what I have come to see post-COVID situation that we are all faced with. Thank you.
That's a huge thing, yeah.
Yeah.
Thank you. Let us conclude this webinar here. And to conclude this webinar, let me invite somebody who has been hiding on this Zoom meeting. We have Zydus CNS therapy lead, Mr. Hardik Shah, who has been instrumental in organizing this event. So, Hardik, can I just invite you to deliver the vote of thanks to Dr. Richardson, Dr. Grace, and also to our audience, please.
Yeah, thank you, Dr. Hardik. So today's session has been a remarkable convergence of knowledge experience and shared commitment to advancing our understanding of temporal lobe epilepsies and psychiatric comorbidities. So, on behalf of Advanced Sciences, I would like to extend our deepest gratitude to our esteemed speaker, Dr. Allison. Your comprehensive presentation on the latest advancements in temporal lobe epilepsies and psychiatric comorbidities was not only enlightening but also provided us with a deeper understanding of the complexities involved in diagnosing and treating this condition. So thank you so much, Dr. Allison. And I would also like to express Dr. Grace. Your insightful contributions during the discussion have added the immense value to this session, the real world perspective and the experiences you shared. You have given us a more nuanced view of challenges and opportunities in managing epilepsy as per the psychiatric comorbidities. So I would like to also acknowledge the audience for your active participation and engagement. So thank you all once again for your participation and contributions. Have a wonderful day ahead. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Can we log off?